Desperate times call for desperate measures. This is especially true for many of us in healthcare, as we find ourselves adapting to new roles and new units, innovating to tackle a new disease while adjusting to a new surreal reality. Hence, in an effort to re-establish some degree of normalcy, we decided to resume the release of our episodes on the Neurocritical Care Society podcast. As I say, the show must go on, and at least now you can listen to something that is non-COVID related for the next 20 minutes. I hope you enjoy this episode. So we've all faced the clinical dilemma of a patient who suffers spontaneous intracerebral hemorrhage while on antiplatelets. Not infrequently, antiplatelets are either not restarted, or there is a prolonged delay in their initiation due to a perceived risk of hematoma expansion. Randomized trials for antiplatelet efficacy in occlusive vascular disease have systematically excluded patients with a history of intracerebral hemorrhage. Hence, due to the paucity of evidence, no guidelines have strong recommendations about long-term antiplatelet initiation after ICH. A question I frequently find myself asking is, are we subjecting our patients to a higher risk of ischemic vascular events by discontinuing these antiplatelet agents? And also whether withholding them truly portends a lower risk of hematoma expansion. What is the safety or benefit of resuming long-term antithrombotic therapy in survivors of intracerebral hemorrhage? To answer some of these questions, Jim Siegler will be speaking with Rustam Al-Shahi Salman, one of the authors of the RESTART trial that was published in The Lancet last May 2019.
My name is Jim Siegler, and I'm an assistant professor of neurology at Cooper University Hospital. It is my great pleasure today to speak with Dr. Rustam Al-Shahi Salman, professor of clinical neurology at the University of Edinburgh, regarding his recently published multi-center randomized clinical trial, RESTART, which evaluated the safety of resuming antithrombotic therapy after intracranial hemorrhage. Thanks so much for joining us on the podcast.
Great to be with you.
So my first question, I've always found it interesting that in patients who've experienced major systemic bleeding, whether it's GI bleeding or GU bleeding, wherever else, if there were a reason to resume antithrombotic therapy, more often than not, providers are perfectly comfortable restarting the antithrombotic. This may seem a bit rhetorical, but why do you think that we've treated survivors of intracranial bleeding differently?
I think that's a great question, Jim. I think this speaks to how we as physicians make decisions at two levels. One's based on instinct and another on evidence. So in our instinct is the severity of the illness that we're concerned about. So gastrointestinal hemorrhage is essentially stoppable and usually mild and rarely fatal, whereas intracerebral hemorrhage, 42% of the patients have died within a month. That goes up to 50% by a year, and about 3/4 of the survivors are left disabled. So instinctively, if we're worried about an antiplatelet drug provoking bleeding again, we'd be much more worried in people who survived intracerebral hemorrhage simply because of the severity of the disease that might recur. So instinctively, I think we're more risk-averse with more severe hemorrhage. Secondly, I think the difference arises due to the evidence base that we have in that in the past, a randomized controlled trial of antiplatelet drug resumption or avoidance has been done for people with gastrointestinal hemorrhage. The result of that trial was neutral. There was no benefit or harm in either direction. And I think GI physicians are likely to feel reassured by that result and are prone to restarting antiplatelet therapy. But of course, for stroke due to intracerebral hemorrhage, we have never had that level of evidence from a randomized controlled trial in the past. So we've largely relied on our instincts, which have led physicians to often avoid, as you say, antithrombotic drugs. And of course, the real thing that shows us we don't know what we're doing in this area is that if you look at surveys of praxis all over the world, the proportion of patients with intracerebral hemorrhage who restart antiplatelet drugs varies from anything as low as about 10 to 20% in some European countries, all the way up to around about 90% in countries like Japan. And that variation in practice tells us we're largely practicing on the basis of instinct and not evidence.
Yeah, that makes perfect sense. And I know as a junior faculty member, I certainly practice in a more risk-averse fashion. So to answer your specific research question of whether it's safe or effective to restart an antithrombotic following intracranial hemorrhage, you and your collaborators designed the RESTART trial. Can you walk us through your methods?
Restart was a very pragmatic, randomised, open-label trial that we conducted in the United Kingdom alone. It really was a pilot phase trial because our intention was to assess the safety of restarting antiplatelet therapy with drugs like aspirin or clopidogrel after intracerebral hemorrhage. And we did this in patients who had had an intracerebral hemorrhage but also had been taking an antithrombotic drug, whether it was antiplatelet or anticoagulant, before that intracerebral hemorrhage because they'd already had some kind of occlusive vascular disease or atrial fibrillation. And what we did was our collaborators at about 122 hospitals would identify survivors of intracerebral hemorrhage, and 24 hours or more after the hemorrhage, they could recruit a patient, enroll them in the MRI sub-study so we could look at biomarkers of cerebral small vessel disease if the patient was suitable for that, and then randomly allocate the patient at a time when both the patient and their physician were ready potentially to start antiplatelet therapy. And the randomization allocated people simply to a policy of starting antiplatelet therapy or avoiding it. And then we followed patients up for, on average, about 2 years, but this ranged from 6 months to up to 5 years. And our primary outcome was recurrent symptomatic intracerebral hemorrhage. So that was our primary safety outcome. But we did measure various secondary outcomes, including all other major or serious vascular events that can happen to these patients, like ischemic strokes and deaths due to other vascular causes.
And you used a very interesting adaptive stratification strategy to allocate patients into the two arms of the study. Were there any major differences between the two patient groups?
So what we wanted to do was ensure that there was reasonable balance between the two arms of the trial for key prognostic variables. And given that we were conducting a phase 2 pilot trial, really, which involved ultimately 537 participants, we didn't want to leave the play of chance to cause an imbalance in the trial arms in important predictors like the proportion of patients with lobar intracerebral hemorrhage, or patients' ages, or their predicted probability of a good outcome, or the type of antiplatelet drug that was used. So those predictors that may influence the risk of recurrent intracerebral hemorrhage were balanced using minimization algorithm, which, as you said, is an adaptive way of, as the trial goes on, ensuring that the two arms of the trial are pretty well balanced according to these key minimization factors. And ultimately, the paper in the Lancet shows in the baseline characteristics table that there was actually very good balance between the two trial arms on most key predictors of outcome. And I suppose for physicians who look after patients with intracerebral hemorrhage, one of their key concerns would be the proportion of people with lobar supratentorial intracerebral hemorrhage, and that was exactly 62% in each of the trial arms, start and avoid antiplatelet therapy.
Moving on to the results, how did the two groups do with respect to the primary outcome of recurrent symptomatic ICH, as well as all of your pre-specified secondary outcomes?
We set out to do this trial expecting there to be a higher risk of recurrent intracerebral hemorrhage with resuming antiplatelet therapy, mainly because in the Antithrombotic Trialist collaboration of randomized trials, there was a non-significant but 67% increase in the risk of hemorrhage with the use of antiplatelet therapy, for example, after ischemic stroke or myocardial infarction. So we had to, a priori, assume that there might be an increase in the risk of hemorrhage. The question was, how large would that increase in hemorrhage be, and might it exceed the known benefits of antiplatelet therapy for reducing occlusive vascular events, heart attacks, for example? So we were extremely and pleasantly surprised to find that there were half as many recurrent intracerebral hemorrhages in the group allocated to starting antiplatelet therapy as there were in the group that avoided antiplatelet therapy. So, as I already said, there are 537 patients in the trial overall, and 268 were analyzable in each arm. And in the group who avoided antiplatelet therapy, 23 patients had a recurrent intracerebral hemorrhage, and in the group who started antiplatelet therapy, there were 12. So that's a hazard ratio of 0.51 in favor of antiplatelet therapy, and the p-value for that was 0.06. So we obviously got our statistician to check the analyses many times because this was completely contrary to what we were expecting. But because this is an open trial. We were aware of what antithrombotic drugs patients were taking, so it was very clear from the adherence to antithrombotic therapy that had been allocated that adherence was very high immediately and only declined to about 85% adherence by 3 years of follow-up. So there was very good adherence to the allocated antithrombotic strategy. So this was a surprising finding on the primary outcome. We looked at various secondary outcomes, as you mentioned, including all major hemorrhagic events, all major occlusive vascular events, and the composite of those two, and there were no significant findings on those composites. But in our protocol, we had said we would look at the composite outcome of all major or serious vascular events, as had been defined by the Antithrombotic Trialists Collaboration, who put together the individual patient data meta-analysis of randomized control trials of the effects of antiplatelet therapy showing clear benefit. And that composite outcome of non-fatal stroke, non-fatal myocardial infarction, or death of a vascular cause was statistically significant in favor of starting antiplatelet therapy. So P of 0.026 for that comparison. But that was one of many secondary outcomes, and I think one needs to take that finding with a pinch of salt. It's consistent with what our expectations would be, but we should really focus on the primary outcome and this surprising finding.
Yeah, I totally agree, and overall very exciting and promising results. Like you said, and I know that I was not the first to be surprised by these results, but why do you think that the effect estimate favors restarting antithrombotic therapy after ICH as far as the lack of observed benefit prevention of thrombotic events?
Yes, that's a great question, Jim. Again, given how surprising this finding was, we immediately doubted ourselves, and the first hypothesis has to be, were many of these apparent bleeds actually hemorrhagic transformation of ischemic stroke, which we frequently see in our clinical practice? So, for example, were we over-counting of ischemic stroke as a primary outcome in the group of patients who avoided antiplatelet therapy? I'm really grateful to the British Heart Foundation, who encouraged us to scrutinize the brain imaging of patients, both pre-randomization and to scrutinize imaging during follow-up. And we had an expert panel of neuroradiologists who reviewed all outcome event imaging blinded to treatment allocation, and they clearly had an option for categorizing the stroke outcomes as ischemic stroke, hemorrhagic transformation of an infarct, or what appears to be spontaneous, non-traumatic, or primary intracerebral hemorrhage. And they'd coded all of these primary outcome events as spontaneous intracerebral hemorrhage. We reviewed the imaging, and they don't look like hemorrhagic transformation of an infarct. So I think the first thing to dismiss is the possibility that this outcome may be spurious in some way because we've misattributed the outcome. So then I think we have to ask ourselves, well, is our assumption that recurrent intracerebral hemorrhage in patients with quite severe small vessel disease due to primarily rupture of a vessel, that somehow antiplatelet therapy leads to an increase in the risk of small vessels in the brain rupturing, and instead consider the possibility that because recurrent hemorrhages were more common in the group who avoided antiplatelet therapy, that maybe thrombosis in a vessel may be the trigger for what turns out to be a ruptured vessel and spontaneous intracerebral hemorrhage in these patients. And conversely, that antiplatelet therapy may reduce the risk of that thrombosis and therefore reduce the risk of recurrent hemorrhage. That's one mechanism. Of course, it's very difficult to prove that because demonstrating that at autopsy or on imaging is quite hard. The second hypothesis, where there is some support from the intracranial aneurysm literature, is that we know that evidence of vessel wall inflammation in aneurysms is found both in unruptured aneurysms that then rupture, but also on non-invasive imaging. It appears that in small randomized studies, patients with unruptured intracranial aneurysms who take antiplatelet therapy seem to have less inflammation in the walls of their aneurysms, and maybe that's associated with a lower risk of bleeding. Whether that is the same in patients with small vessel disease remains to be proven. But I think that thrombosis and inflammation are the two mechanisms that may explain our result.
Acknowledging that this was phase 2 randomized clinical trial, what next steps need to be taken in order to strengthen the evidence about the safety of restarting antithrombotics after ICH? And do you have any concerns about particular groups where there may not be equipoise, like lobar hemorrhages?
As I mentioned earlier, we were very keen imaging as much as possible, but acknowledging this would be a small trial, we knew that we wouldn't be able to test any major hypotheses about whether the effects of antiplatelet therapy were different, for example, in patients with lobar versus non-lobar intracerebral hemorrhage. But we did also look at other small vessel disease biomarkers for a more nuanced view of what the underlying cause of the hemorrhage would be. So in the main trial itself, we looked at various subgroups, and these were the same groups we used in the minimization algorithm we mentioned earlier, and there was no statistically significant interaction between things like intracerebral hemorrhage location, lobar versus non-lobar, or patient's age, or history of atrial fibrillation, the type of antiplatelet used, and the effect on the primary outcome. So in the subgroup plot, all the effect estimates are on the same side of the line, favoring starting antiplatelet therapy. And that includes patients with a lobar intracerebral hemorrhage. But of course, the majority of people with lobar intracerebral hemorrhage have arteriolosclerosis as the underlying pathology. Only a small proportion of them, somewhere between 10 and 20%, have pure amyloid angiopathy as the underlying cause. So we would want to use MRI to identify them. And we did that in the separate imaging sub-study that was published in the Lancet Neurology. And our key primary biomarker of interest was the presence versus absence of cerebral microbleeds. And from observational studies from the Boston group and others, there was a suggestion that maybe people with microbleeds were at higher risk of recurrent hemorrhage. It started antiplatelet therapy, but we found absolutely no evidence in the imaging sub-study. And again, we found that the hazard ratio in people who had cerebral microbleeds was really quite different from what we might have expected. And the hazard ratio was 0.3. in favour of antiplatelet therapy on the primary outcome of recurrent intracerebral hemorrhage in patients with 2 or more cerebral microbleeds versus 0.77 in patients with no microbleeds. So this was really going in the opposite direction again of what our expectations were from prior observational studies. I think it would be very nice to have a much larger imaging sub-study to be really confident about those findings. And of course, coming to your first question, really, we need a definitive main phase trial now, not just with 537, but more like 5,370 patients to really be confident about our findings, to seek to reproduce them, and also have enough power to look at subgroups in a bit more detail.
I completely agree. And I think we are left with, more questions than we have answers for. And like you said, we do need some more data to kind of either confirm these findings or to give us more evidence one way or another. Again, this is Dr. Rustam Al-Shahi Salman, Professor of Clinical Neurology at the University of Edinburgh. I'm Jim Siegler for the Neurocritical Care Society podcast. Thank you so much for joining us.
Well, thank you very much for your time today, and grateful to your listeners for their attention.
The NCS podcast series is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, and advocacy in neurocritical care. Our production staff includes Fawaz Al-Mufti, Lamani Ballou, Mike Brogan, Josh Levine, Benjamin Miller, Sterain Shepard, Jim Siegler, Sarah Stern-Nezer, and Chris Zamet. Our senior producer is Bonnie Rousseau. Our administrative staff includes Bonnie Rousseau and Angel Gindel. Music is created by Mohan Kadapali from the Division of Neurocritical Care at the University of Miami. The NCS podcast series is available on NCS On Demand and wherever you may listen to your podcasts. For more information, please follow us on Twitter @Neurocritical or on Facebook. I'm Fawaz Al-Mufti, and thanks for listening.